April is adrenal month, and the adrenal glands are probably some of the most important glands in the human body. As everything that's important in the human body, we have two adrenal glands. They are small glands on top of each kidney, and they secrete basically 3 to 4 categories of hormones. There are different zones in the adrenal gland called reticularis and glomerulosa and all these unpronounceable things, but all you need to remember are the hormones that the adrenal gland secretes. The first one is cortisol, which is a life hormone. You cannot live without cortisol. The second one is aldosterone, which is in charge of the balance of sodium, potassium, and blood pressure in the body. Again, you cannot live without aldosterone. The third hormone is called DHEAS, which is an androgenic hormone. It produces estradiol, which is the estrogen. It produces testosterone. And these are basically the main hormones of the adrenal glands. You can live without one adrenal gland because the other one takes over in the majority of the cases. Ideal, obviously, you have to have both adrenal glands intact. Evaluation of the pathology arising in the adrenal gland is difficult and should be left in the hands of an endocrinologist. So we will take each pathology separately. One of the most common forms of pathology in the adrenal gland are adrenal nodules, and these are usually incidentally discovered when you have a CAT scan of the abdomen or of the kidneys. These are growths on top of the adrenal gland. They may be on both sides, or they may be on one side. Each adrenal nodule has to be evaluated for possible hormone secretion. They have to be evaluated of how they look on the CAT scan, whether they look benign or malignant, whether they are avid for taking some of the Huntsville units or contrast. And then from a biochemical point of view, you have to ascertain whether these tumors, these nodules, secrete aldosterone, secrete cortisol, secrete DHEAS, testosterone, estradiol, and so on. So again, it's a complicated assessment. After the endocrinologist assesses whether these adrenal nodules are secreting hormones or not, then you have to assess when the next imaging study will be done and how to advise the patient what to do if the tumor grows in size or not. Sometimes you don't have to do anything else depending on how the tumor looks on the CAT scan. So again, it is not an easy assessment, but if you were ever told that you have an adrenal nodule, this should be assessed by an endocrinologist. Another pathology of the adrenal gland is Adrenal Disease, which is pure primary adrenal insufficiency. In other words, you do not have cortisol and you do not have aldosterone. This is a life-threatening disease. You cannot live for more than 24, 48 hours in the absence of having aldosterone or cortisol. This has to be assessed again by an endocrinologist, and treatment has to be done. You have to know the exact doses of hydrocortisone or prednisone or whatever cortisol form your doctor will advise. You have to be assessed for doses of aldosterone, monitored on a regular basis depending on the results of other hormones. You have to have emergency hydrocortisone available if you have a crisis. And very important, you have to have a medical alert bracelet stating that you have primary adrenal insufficiency, that you are taking hydrocortisone and aldosterone. This is a must, because if you are unconscious or you have an accident, when EMS arrives and they don't know that you are taking hydrocortisone, you can be in trouble. So make sure that you have a medical alert bracelet. You know how to adjust the hydrocortisone if you have a fever or you are sick, how to adjust your medications in case of surgery, and how to monitor and how to have an emergency high-dose cortisone available if you are in a crisis. Also, your family needs to know how to address this. Now, there is a form of diagnosis online called adrenal fatigue. This does not exist. It's like saying you are a little bit pregnant. You either have adrenal insufficiency, adrenal failure, which is a medical emergency, or you do not. Do not accept the diagnosis of adrenal fatigue. In order to make the diagnosis of adrenal failure, you have to have something that's called an ACTH stimulation test, where we give you a pituitary hormone and we assess the response of both cortisol and aldosterone coming from the adrenal gland. Without having this gold standard test, nobody can tell you whether you have adrenal insufficiency or not. In cases of emergency, you can be started on medications and then do the test later, but you should have a test. Again, the concept of adrenal fatigue does not exist. Another form of adrenal pathology is an over-secretion of hormones coming from the adrenal gland. As we said, there are 3 different hormones: aldosterone, cortisol, DHEAS, and testosterone, and they have to be addressed separately. The first one, an over-secretion of cortisol, presents the so-called hypercortisolism, called also Cushing's. It is a more rare form than the overproduction of cortisol coming from the pituitary gland, and it has to be carefully diagnosed with something that's called the dexamethasone suppression test, 24-hour urine collection for cortisol, and so on. Again, it is a very specialized form of assessment, and it needs to be left to an endocrinologist. Another form of excessive secretion is that of aldosterone, and this can be produced by a tumor or by bilateral enlargement of the adrenal gland. You have to be assessed if you have high blood pressure or a low potassium. It is a specialized form of assessment, and sometimes you have to do actually measurement of the aldosterone coming from the adrenal glands, which involves a rather invasive form of catheterization, putting a small catheter in the 2 adrenal glands and measuring the hormones. So again, this should be left at the discretion of a specialist. Many times when people have resistant high blood pressure or low potassium, they have to be assessed for the possibility of excessive aldosterone secretion. And this is a rather novel idea and should be, a lot of people should be screened for the possibility of an aldosterone secreting tumor. Also, resistant forms of obesity or resistant forms of diabetes have to be screened with something that's called the dexamethasone suppression test to see if they have high cortisol levels. And this is a rather simple test. You take a small dose of dexamethasone, another hormone, and they check the cortisol the following day. It is very, very important to do that if you have diabetes, which in spite of you following the diet and having the best medications, your diabetes is still out of control. There's a specific form of hypersecretion of some hormones coming from the adrenal gland, which is called congenital adrenal hyperplasia, a mouthful of a borderline enzyme deficiency, which is called 21-hydroxylase deficiency, because the adrenal cascade of manufacturing hormones is very, very complicated, and it's one of those questions that makes you fail the board exam because you have to remember at least 20 different hormones. Everything starts with the cholesterol, and from there, different enzymes are cleaving the cholesterol, and eventually you are going to have cortisol, testosterone, estrogen, and aldosterone. Now, if you have an enzyme deficiency, then this end product of the adrenal gland, either cortisol or aldosterone, they do not end up being secreted properly. And if you have a severe form of this deficiency, you can have major problems at birth with very, very low blood pressure, something that's called hypertensive and salt crisis, and you don't know whether the genitalia of the newborn, you don't know whether it's a boy or a girl. Now, these are very severe forms of congenital adrenal hyperplasia, and newborns are screened in this country for the possibility of this entity. However, the most common forms of this congenital adrenal hyperplasia is something that we call heterozygous. So you only have one gene from one parent. And they usually present in girls where they can present with premature puberty, or they can present with excessive hair growth and acne and irregular periods later on in life. The majority of these cases are actually misdiagnosed only as polycystic ovarian syndrome, when in fact they have an enzyme deficiency. So the moral of this story is that if you do have a diagnosis of polycystic ovaries, you need to ascertain that the patient doesn't have this congenital adrenal hyperplasia because it's important for the future children of this patient. If the patient has a child with a partner who also has a heterozygote form, then the baby may have problems at birth. And in men, this congenital adrenal hyperplasia, when it's not full-blown disease, it's very difficult to diagnose. They may have a little bit of acne, but that's about it. So again, it's very, very important if you have polycystic ovaries to look at this congenital adrenal hyperplasia diagnosis. These are rare forms, and they are more common in people of Mediterranean ethnic origin. And this involves the whole, whether you are Greek, Spanish, Italian, Arab, Jewish, and so on. Why it is more common in this ethnic forum, we don't really understand. So if you have a patient with this ethnic background, with hirsutism as a woman, irregular periods, excessive hair growth as hirsutism, acne, think about the possibility of congenital adrenal